Aloha, welcome to Healthcare in Hawaii. I'm your host, Josh Green, State Senator and Health Chairman over in the Senate and ER physician on the weekends. We've had a really vibrant discussion over the last 2 months about healthcare in Hawaii, our title. We've had CEOs and presidents of companies that are in healthcare. We had the Senior Vice President of HMSA, Hilton Rathel. Beth Giesting from the Governor's Office came and spoke with us. We had George Green, the Healthcare Association President, Christine Sakuda, the head of the Health Information Exchange. We've had leaders from the Native Hawaiian health community, and today I'm very excited to have an absolute expert in a different part of the healthcare discussion, single-payer healthcare. Dr. Stephen Kemble was raised here, educated in medical school at JAPSOM, and then spent a considerable amount of time over at Harvard getting his additional training in internal medicine and psychiatry. He's a healthcare leader in our state. He served as the immediate past president of the HMA, Hawaii Medical Association, and just finished his presidential term just a few weeks ago. So we're lucky to get him away from his work today for an hour and have a vibrant discussion about healthcare in Hawaii. But I wanted Steve here on our program because he knows more about the single payer option than anyone else in Hawaii. That's why I'm honored to have Steve here today. Dr. Kemble.
Thank you very much.
So tell us a little bit about yourself before we dive into the issue.
Yeah, I grew up here. I went to medical school at UH when it was a 2-year school for 2 years, and then finished at Harvard, and then trained in both internal medicine here and in psychiatry. I practiced for a while in the Cambridge area and then moved back here in '85, and I've been in psychiatric practice ever since. I also work in Queen Emma Clinic with the Department of Medicine, helping train internal medicine residents on how to deal with psychiatric issues in primary care. And there I am dealing with the Medicaid population, so I have a particular interest in making sure their needs are met in healthcare reform.
That's one of the reasons that I know it's valuable to have you on, because you both have a lot of policy experience, but you also are still a clinician. I mean, you are in the trenches taking care of people, and I know that over the years we've spoken about how committed you are to making sure everyone has actual health care. But it's not working, is it? What's going on with our healthcare system in the country?
Well, right now our U.S. healthcare costs about 150% of what the next most expensive country costs, and we're roughly twice what the average of developed countries is around the world. We have large numbers of uninsured and underinsured, people who have insurance that doesn't enable them to get appropriate health care. We have deteriorating coverage and benefits. We have a tortuously complex system, both for patients and for healthcare providers, hospitals, doctors. Our healthcare costs are about 18% of gross domestic product and rising, and most other countries are around the 8 to 12% range.
So basically, I'm going to slow it down a little bit here.
Yeah.
So for our viewers, healthcare is very super expensive in our country compared to other countries that are very well developed.
Yes.
We don't get the results that we should for all that money. And we just passed this gigantic piece of legislation called the Affordable Care Act, or Obamacare. And what I'd like you to do today, if it suits you, would be to, throughout the discussion, juxtapose what Obamacare means and what it does to what single-payer healthcare systems would look like and what it would look like for us. Would that be okay with you?
Great, yeah.
Okay, well, why don't we start then? People have heard a lot about the Affordable Care Act, Obamacare. Could you give us like a mini overview, give us a minute or two about what the Affordable Care Act does, and then we'll riff about how that would differ significantly.
Okay. Well, the Affordable Care Act made a decision, or the Obama administration made a decision to stay with the private health insurance model. So the plan was actually written by the insurance industry, by people from the health insurance industry. So it keeps the insurance system, but it reforms it. And that includes things like banning exclusions of pre-existing conditions, no lifetime caps on benefits, no cancellation because somebody got sick, and sort of the worst abuses of the insurance system. And in exchange for those constraints on insurance, it expands coverage to most of the people, or attempts to expand coverage to most of the people who have been uninsured up to now, by requiring both an employer and an individual mandate to have health insurance, requiring people to buy health insurance from the health insurance companies if they don't qualify for Medicare or Medicaid. It gradually closes the Medicare donut hole for drug co-payments, which is very high initially, and gradually closes it. It encourages payment and delivery system reforms that are supposed to reduce or eliminate fee-for-service payment of doctors. And it does involve taxes on both the wealthy and on high-cost plans. Some of the Funding for it has already been reversed, like there's going to be reductions in payment for Medicare Advantage plans that have been reversed. So it's not clear that it's actually going to save money, but it attempts to keep the insurance system but reform it and make it work a little better.
So I definitely don't want to put words in your mouth. Are some of those good things? I mean, when you describe some of it, like the cap on lifetime expenditures or the fact that people couldn't be refused based on pre-existing conditions.
Those are very good things.
Okay. So there is some merit to the Affordable Care Act, but at the same time you seem reticent to endorse it completely. Tell me a little bit why.
Well, a lot of the features that might have been helpful have already been reversed, like the reduction in excess payments to Medicare Advantage plans. I don't know if you realize this, but Medicare Advantage is privatized Medicare, and it costs about 14% more than regular Medicare does. So it's not actually saving us any money, and originally Obamacare was supposed to rein that in and keep the cost closer to regular Medicare, but that's been reversed by the negotiations with the insurance industry.
So compromises were made, and we're going to get into very quickly what the beginning of the vision for single payer. But just before we started our show, my producer said, you know, I was driving down the road with a few people and they were lamenting that their rates are going up this year on their plans. Why is that?
Well, the real drivers of the excess costs in the U.S. healthcare system are primarily its administrative complexity, which is made worse by the Affordable Care Act, and access problems. People who can't get access to care in the most cost-effective settings, usually outpatient, and end up in the emergency rooms and hospitals, which I'm sure you see all the time
every night
as an ER doctor. And those things are not going to be solved by Obamacare. The kind of measures that would have addressed those problems are not even included in the plan. So I think it's not going to control costs, and it's not going to guarantee access enough to really bend the cost curve.
So, though there are some good pieces to the Affordable Care Act that, like, we had to deal with the 45, we both agree on many of these points, but to have a country with 45 or 50 million uninsured individuals was a catastrophe. But just because we're getting them insurance now through the Affordable Care Act does not guarantee cost containment yet, nor does it solve some of the more nuanced problems like access.
Access, quality, those things are not actually going to be helped much by Obamacare.
And we're going to get into that a lot about access to Medicaid and Medicare in the coming discussion. But okay, so we have a basic idea of the framework for Obamacare, which was get most people insured, put a mandate on them, don't deny people, try to keep the lid on.
Right.
Tell me the 101 on single-payer healthcare coverage.
Okay, single-payer, start with a definition. Single-payer means public financing, but private and independent care delivery. In other words, doctors can still be in solo practices, hospitals can be, private, nonprofit entities, but the payment comes through the government. You collect taxes, but some combination of payroll taxes on the employer and the individual.
Right.
It goes into a single system that pays everybody from that system. All doctors are included, all hospitals are included, patients have free choice of whoever they want to see, and the administration is much, much simpler and much less complex, and therefore much cheaper.
Now, what's the current administrative cost in most plans across the country? What does it cost usually from the admin side?
That's a good question, because prior to Obamacare, the administrative cost for private health insurance ranged anywhere from 8 to 30%.
Wow.
Something like that. The administrative costs for Medicare were running around 3%.
Got it. So already Medicare was running at least an efficient system.
Yes, much more efficient. Now, with Obamacare, we have a limit on what's called the medical loss ratio, and that's insurance speak for the percentage of the healthcare dollar that pays for actual health care. And Obamacare says that can't be more than 15 to 20%, depending on the size of the employer.
That still sounds kind of high, though.
It's still a lot higher than Medicare. And the insurance industry negotiated with Obama administration to count medical management costs as health care, not administration. And that makes the medical loss ratio meaningless, because those can easily be 5 to 10% of the healthcare dollar. They can all be spent on obstructing healthcare, and they get to count it as healthcare. So the medical loss ratio now means nothing.
Okay, so back into kind of lay speak for me and others, even though I'm an ER doc, we ER docs sometimes can be somewhat obtuse. So when people ask where my healthcare dollar, you're saying it's still a lot of it can be absorbed by the insurance industry.
Yes.
Okay.
Yeah, and they may claim their administrative costs are 10%. They could actually be double that.
How do we do in Hawaii? How does it kind of stack up against other places?
Well, with our Prepaid Healthcare Act, we've had relatively broad coverage. We've always had an employer mandate, even though we haven't had an individual mandate, and that has spread the cost of healthcare broadly across the population. So we've generally had the best benefits and among the lowest premiums of any state for commercial health insurance, employer-based health insurance.
Okay.
So that, we started off in a relatively good position for that. The problem has been the sole proprietors, the part-time workers, 19 hours or less, the family members whose spouse doesn't include family in their insurance. Those are the people that have been left out. And then there's all kind of problems with Medicaid.
So, okay, so let's see. In previous discussions that I've had with many people, yourself included, we've been around 9 or 10% uninsured.
Yes.
Okay, and then there are people that are underinsured because they have somewhat crappy plans, right? So, now the cost of our premiums, I understand they're relatively low compared to the rest of the country. So, on the whole, we've been doing better than some parts of the country, but we still have an issue.
A big problem. Yes.
Okay, and we're going to get, as we go through the program, some of to the core of some of the problems, because we still spend a lot on some healthcare that doesn't deliver good healthcare, right? Okay, so again, to frame where we are, the country had a massive problem, 50 million people uninsured. Along comes the government, they passed this big bill. Hawaii already had a decent situation, but not perfect, and there were examples in other countries where they were doing it better.
Yeah.
Now the Affordable Care Act has passed. How does that impact us when we've already been ahead? Are people now going to suddenly be covered?
Well, we've made a big effort to try to preserve the advantages of the Prepaid Healthcare Act and at the same time implement Obamacare.
Okay.
One of the things about that is that for employer-based insurance, they can only offer the top 2 middle levels of Obamacare plans.
The fancy plans, you mean?
Yeah, in other words, the ones that cover 90% of the cost of health care and 80% of the cost of health care. That's what's required in Hawaii's Prepaid Healthcare Act.
Okay.
Individuals will be offered silver and bronze plans as well that only cover 70 or 60% of the cost of health care.
Yes.
And that can often be unaffordable. For example, with Obamacare, if you have an income of $30,000 a year, you qualify for subsidies both for the premiums and also for your deductibles and copays.
Okay.
And those subsidies mean you can't spend more than $6,300 on health care when your income is $30,000. Who has an income of $30,000 and can afford $6,300 for health care? Nobody.
Right.
That's an unaffordable copayment, even with the subsidies.
Right. So the system attempted some fixes,
Yes.
and some people benefited, but we still have a flawed system.
Problem, yeah.
And we still have a flawed system because it is still inefficient.
Yeah.
There's still going to be a lot of money spent towards administration.
Yeah.
What other concerns do you have right now about the Affordable Care Act?
Well, I have a lot of concerns about the effort to steer away from fee-for-service, because this is based on the assumption that the problem is that doctors are delivering too much unnecessary care and patients are demanding too much unnecessary care. And both of those assumptions are not actually based on much evidence at all.
Okay.
I think that the biggest drivers of excess costs are actually the administrative overhead, which is much higher here, and the lack of access problems. And by blaming doctors and patients, the implied solution is we need to restrict care more. We need to make it more expensive to get care. We need to give doctors incentives not to deliver so much care. And when you already have a nationwide shortage of doctors, people who can't get access to care, that only makes things worse. So it's like we're both trying to restrict care and we're also trying to make it more coordinated at the same time. We're going in opposite directions. I think the system is schizophrenic and needs a psychiatrist.
Okay, well, we do have a psychiatrist today. We're going to head towards our first break, and then we're going to talk specifically about single payer and what it would look like in America. So we'll take our first break. I'm Josh Green with Healthcare in Hawaii. Thanks for joining us.
Aloha, I'm Jay Fidel, founder of ThinkTech Hawaii. We are a digital media nonprofit that covers things that matter to tech, energy, diversification, globalism, and progress for our state, the state of Hawaii. We broadcast on community television and on Oceanic Cable Channel 16. We also stream our shows and interviews live on the internet as both radio and video and of course, we post them here on YouTube. We collaborate with the Hawaii Venture Capital Association to present monthly luncheon programs on subjects of interest to the business community, and we write for the Honolulu Star-Advertiser. ThinkTech works hard to raise public awareness in Hawaii. Check out our website, thinktechhawaii.com, and come to our YouTube channel, ThinkTech Hawaii. We hope you support our mission and that you like our work. I'm Jay Fidel. Mahalo.
Aloha, welcome back again. I'm Josh Green, your host at Healthcare in Hawaii. Today I'm joined by an expert in single-payer healthcare, Dr. Stephen Kemble, who's an internal medicine and psychiatry trained physician from Hawaii and Harvard. Stephen has been spending much of his time working on better plans, better ways to provide healthcare in our state and across the country. Stephen was the immediate past president of the Hawaii Medical Association, one of Hawaii's preeminent physician groups. He also has been a part of Physicians for National Health Plans, the one-payer states, a lot of significant groups all coming together to try to find a better way through single-payer healthcare. In our first 15 minutes, we were able to distinguish in some ways between our current situation in healthcare and access, the new changes coming from the Affordable Care Act or Obamacare, and just we kind of nibbled around the edges about what single payer might look like. But now I want to turn to Stephen and talk about some of the problems that are inherent in our system of Medicaid, where we have many thousands, about 285,000 individuals in the state of Hawaii on Medicaid insurance. That's insurance plan for people who are indigent, and then Medicare and the insurance plans in general. So let's talk about Medicaid, Steve.
Medicaid illustrates a lot of the problems and why I think some of the proposed solutions aren't going to work, because they've already been tried and they're not working. But prior to 1994, Hawaii had a fee-for-service Medicaid system run by the state, where doctors delivered care, hospitals delivered care, they sent the bills to the state, they used HMSA as a fiscal intermediary, and eventually everybody got paid. There were problems with lack of predictability in the budget. They would run out of money toward the end of the year and have to defer payments, so you might have a 2-month delay in getting paid, but then eventually they would work it out and you get your money. The pay was relatively low, the patients were sicker than average, but the hassles were minimal, and almost all doctors in Hawaii participated with Medicaid. At least 2/3 were participating with Medicaid.
And let me frame that again, why it's so important we talk about that, because we only have about 1.3 million people in the state. We're talking about almost 300,000 individuals that are in the plan, and these are taxpayer dollars, if I'm correct, about $2 billion a year that are being spent on this program.
Right.
Huge part of our budget. Okay, so you've established that it was simpler, but at least everyone was taking care of people.
Right.
Okay.
Now, because the budget was unpredictable, the legislature didn't like having a crisis at the end of the year every year, which is understandable. So they bought into this idea that the problem is government inefficiency, and what we need to do is privatize Medicaid, contract with private managed care organizations who would then manage Medicaid, make sure that unnecessary care was reined in, and that the whole thing was made more cost effective through the wonders of the marketplace and competition among plans and that kind of thing. So they developed the managed care system for the categories of Medicaid dealing with aid for dependent children and general assistance, the disabled adults. But they didn't do it for the aged, blind, disabled category, which is the people with chronic serious disability, the seriously mentally ill, and the elderly.
That's about 35,000 people, something like that.
And those were left in fee-for-service Medicaid until 2009. So during that period, the managed care plans came in and they started requiring prior authorizations for everything, restricting formularies, things like that, which was very burdensome for doctors. But everybody worked at jumping through the hoops. Psychiatry was perhaps the worst because we had to get prior authorization for everything we did. And it started out, you would get 3 or 6 visits and have to do another treatment plan. But we all got good at developing systems for keeping track of authorizations and processing the treatment plans efficiently. So after a while, nobody got any denials for administrative reasons anymore. And in fact, for the next 15 years, I never got a single clinical denial. Every patient I saw, I always got the authorizations. I just had to learn how to jump through the hoops efficiently.
Okay.
So it was more hassle, and I think there was some reduction in the doctors willing to take Medicaid.
Okay.
But the plans started to back off some on the prior authorizations. They would allow more visits. They realized it was costing them money to deal with this stuff as well as the doctors. And so they started becoming more reasonable, and it got a little easier to deal with. HMSA for a while went to a system where they stopped managing everything and they would only manage outliers. You know, doctors who had practice patterns that were way off the norm,
spending
or
weird amounts of money, or doing weird tests,
things, or patients who were in and out of the emergency room or high risk. They would provide friendly case management to help coordinate their care, to support the doctor in coordinating the care, and that was fine. To me, that's the way it should have been done in the first place. Then in 2009, the state turned, and this is during the Lingle administration, they turned over the aged, blind, disabled population to two new mainland for-profit managed care companies. And they went right back to the same kind of restricted formularies, prior authorizations, making you jump through all kinds of hoops, but even worse than before. And the result is that half the doctors who signed up with those plans in 2009 because they were already treating Medicaid patients have stopped taking new Medicaid patients. So we've lost half the doctors in terms of availability to new patients in 4 years.
And this is a big problem, I gather, because we start from a place where we have a shortage of physician providers. We have nurse practitioners, of course, and physician assistants, but we have a general shortage of providers to take care of all of us. Then payments are pretty low for the Medicaid plan in general, so physicians have historically maybe had some reluctance to care for people. But like you said, based on the history, they realized it was important, they jumped on board, they worked through the kinks, and then we add this new rule in 2009. You're saying now we have fewer physicians willing to take care of people?
Much fewer. For psychiatry, it's almost impossible to find a psychiatrist who will take Medicaid patients with those plans. You know, I don't know of anyone who's open to new referrals, or maybe a couple, but I don't know who they are. And our ER and hospital costs for psychiatric problems have gone up 30% in the last 4 years. So this is not saving us any money.
Right, and that was a point made very well by George Green and the Healthcare Association, especially in their large report, which was that we have many preventable opportunities for people with mental illness, and the costs are going through the roof. Big problem for the hospitals as well. So, okay, so the system you're saying is inefficient, it is discouraging physicians from providing the care to the people that need it, and we're living with it right now. Okay, now add on the Affordable Care Act. How does that impact that?
Well, the Affordable Care Act expands Medicaid. Well, technically it expands it to everyone up to 138% of federal poverty level, but in Hawaii's case, we started out at 200% and cut it back to 138%. And it also now allows those who have low income but also have assets like a house or, you know, some kind of investments to get Medicaid based on their income alone without an asset test.
Now, it's my understanding in talks with the directors of Medicaid here in the state that they're expecting our number to go from the 285 or 290,000 people up to as much as maybe 340 or 350,000 Medicaid patients. Is that right?
So all the people that apply to the exchange and turn out to have low enough income to qualify for Medicaid, even if they've got assets, will now be told, oh, you qualify for Medicaid, and they will be steered by the connector, the health exchange, into Medicaid.
Okay.
And so we have a system with a severe shortage of doctors, especially those willing to take Medicaid, and now doubling of the population.
Yeah, that is a real concern for me. So a problem you're saying that hasn't been well solved by the current system. And I think that's a very good case that you brought up. I'm glad you brought that up because it's illustrative of what I'm wondering about nationally, which is we're going to add 45 million people into the covered class. Everyone will be covered, hopefully, which is a good thing, but who will take care of them? Where is the increase in providers? Where are the new young physicians going into primary care? Where are the nurse practitioner academies and physician assistant academies going to be able to step up? Do we have the providers to take care of everybody?
Well, we have a shortage already, but when you combine that with, you know, 2/3 of them are not accepting Medicaid, then you end up with a severe, severe problem. And the Affordable Care Act includes incentives to provide more coordinated care, presumably more cost-effective care, to do electronic medical records, things like that. But those incentives mean nothing unless you can get the doctor to participate. Otherwise, if you only have a third of the doctors participating, you can give them all the incentives you want, and if they don't bring doctors back in, it won't do you any good.
I heard a rumor, you're a good person to ask about this. I heard a rumor that after Romney passed the healthcare reform in Massachusetts, that in the ensuing years there were some of these challenges, that they didn't have enough providers to cover, to provide care for all the people, and some providers were opting to not take coverage that wasn't going to pay well. Did they have a mandate that they told doctors, if you want to have a medical license, you're going to have to participate? What happened with that?
No, they don't. I don't think any state has been able to impose that mandate. You have states like California whose Medicaid payments are so low that if you mandated it, you'd put all the doctors out of business.
Got it.
You can't just mandate something without some mechanism to be sure it stays reasonable. Otherwise, you destroy the whole system.
Yeah, I don't support that. I was just wondering about that. And now you've spelled out you painted a picture of a lot of additional people getting insurance, getting Medicaid insurance, but they may not be able to find a primary care provider. Where will they go? They'll come see me in the ER? Is that the idea?
I'm afraid that's what's going to happen. I mean, it's already happening, but it's going to continue to happen, and I don't see that changing without some way of getting the doctors back in. Now, one of the things I've been interested in for Medicaid is there are some Medicaid programs that have physician-driven care coordination. North Carolina is my favorite example. North Carolina has a system where the whole Medicaid system is one system.
Yes.
There aren't competing managed care plans. It's one system. It's run by groups of doctors like the Medical Association, the academic doctors with the medical schools, the Hospital Association, and the state DHS. They run the program together. It includes extra payments for patient-centered medical homes, community care teams that reach out to those who would otherwise fall through the crack or have problems that can't be dealt with within the doctor's office, and you need someone who can go in the community and reach out to people. They have physician-directed quality improvement to try to make sure that care stays cost-effective and is run by the doctors and they feel ownership of it. They have and they've also kept fees close to Medicare rates, which is a little better than most states. The result is they have a high level of physician participation. The doctors like the program, they trust it, they believe in it, they want to participate in it. Patients have much better access to care than they do in most other states. Their Medicaid costs are around the national average, but the rate of growth is the slowest in the whole country.
Okay, so you're saying that in one model, at least, in North Carolina, the doctors basically took control of the program. They got paid directly? Is that how it went?
Yeah, they get paid fee-for-service by DHS, but there's an administrator. But
so there's not an HMO in the middle?
No, that's right.
And they have kept the rate of increase, so it's not going up really fast, the cost. It's kind of stayed flat, is what you're suggesting.
We're running around 10, 12%. They're running around 3% rate of growth.
Which is a concern as a senator. When I see a budget that's already $2 billion, 10% growth is something that we might not be able to afford. Let me just ask you kind of briefly before we go on. It's expensive, right? We know this. If we're going to defer patient care from the primary care setting to the ER, that's 10 times as expensive.
Right.
How's that going to be sustained, or is this whole thing going to crumble quickly?
Well, that's what North Carolina did, is they're focused on keeping people out of the ER and the hospital if their condition can be dealt with in the doctor's office or in the community with physician support and the community care teams together. And they do a good job of limiting ER and hospital use, and they keep the savings from that to help keep physician pay reasonable and to fund the community care networks and things like that.
Yeah, and I think that that's going to be very important. We're heading into our next break, but I think it's good to remind people at this point that there are so many people on Medicaid and so many people on Medicare, and then additional large numbers of people that have their health care covered by union work and so on. It's a giant percentage, isn't it, of people that are already getting subsidized health care coverage.
Yeah.
What is it?
Well, the U.S. government, either state or national government, funds 60% of U.S. health care. Other countries with single-payer systems spend 60% of what we spend altogether. So with just what government spends, you eliminate all the out-of-pocket costs, all the employer costs, you could cover everybody with a single-payer system.
An interesting place for us to stop and segue into our next 15 minutes. But again, I'm going to take a break here, Stephen. It's been excellent. Josh Green with Healthcare in Hawaii. Let's take a minute break and we'll be right back.
Aloha, I'm Nicole Horry for ThinkTech. For nearly half a century, the Hawaii Foreign Trade Zone No. 9 has brought the benefits of the Foreign Trade Zone program to Hawaii businesses and entrepreneurs. DBET, the Department of Business, Economic Development and Tourism, operates Hawaii's Foreign Trade Zone program to encourage international business and economic development. The Foreign Trade Zone's mission is to increase the amount of international trading activity in Hawaii, thereby providing employment opportunities for the residents of our island state. For more information, see ftz9.org. I'm Nicole Horry. Mahalo.
Aloha. Again, welcome back. This is Josh Green, your host at Healthcare in Hawaii. Today I'm joined by Dr. Steve Kemble, physician, psychiatrist, internal medicine doc, who trained here in Hawaii, went to Harvard, is a policy expert on single-payer healthcare systems, and has really been a leader on this matter for many years here in our state. He also has a national role to play in his communications with many other organizations that are similarly minded. In our first 30 minutes, we've been able to discuss where healthcare is today, what the impact of the Affordable Care Act is, and some of its challenges. We just spoke about the Medicaid problem, which is it's difficult to find a physician if you're on Medicaid, and it just might get tougher and more expensive. We're worried about that. But now I want to turn to Steve and ask him, tell us about the health insurance model in general. What do you think the challenges are?
Okay, my biggest criticism of Obamacare is that it's built around the insurance system. And I think the insurance system is a wrong model for financing healthcare, and I'm going to explain why that is.
Okay.
Competition in healthcare financing is actually counterproductive. It doesn't work, it doesn't help in any way. Two dominant characteristics of healthcare are the fact that a high percentage of the population has known health risks because they have pre-existing conditions. And insurance is a system to manage risk, and it does that in two main ways. It does that by risk pooling, where you have everybody pool their money, and then those that get sick or have an expensive complication get paid when needed.
Right.
And this works fine for risks that are expensive, infrequent, and unpredictable, like your house burning down. So everybody with homeowners insurance pays into the system. If you're the unlucky person whose house burns down, the money's there to pay for it.
Okay.
But when a lot of the population has known risks, like a third of the population has pre-existing health conditions,
Right.
then the incentive is not to offer a better plan, it's to avoid risk. So the insurance companies try to avoid signing up sick people or to avoid paying claims, things like that. And this is the nature of the business model. Mm-hmm. If you use that business model, you have that problem. So Obamacare tries to correct for that by limiting pre-existing condition exclusions and things like that. But it still allows the system to charge 3 times as much for older people as for younger people. It still has high deductibles and co-payments, which make health care unaffordable for those who need it the most. Mm-hmm. So there's still a lot of holes in the system.
So it was just a partial fix is what you're saying?
Right.
Okay.
Now, I mean, ideally what you want is a single risk pool where everyone is in the same risk pool, everyone gets this care in the same delivery system, and it's all prepaid through progressive taxation, which would end up replacing health insurance premiums, out-of-pocket costs, deductibles, all that stuff, and in total costing 30–40% less. Even though it's called a tax, the total cost is significantly less for that kind of system.
We sat together on what was in some circles a controversial task force, but there was some good work that came out of it, some good discussion certainly that came out of it, where we talked about what would it look like to have a single-payer healthcare system in our state. And I know that we didn't get to all the questions that you and I might have liked to, but if I'm not mistaken, when we did get the ultimate report, they did say that if we did single-payer for the state of Hawaii, the cost would be lower for everybody under, I think it was something like $106,000. If I recall the number, it's been about 6 or 8 years. But basically, for everyone of modest or even somewhat significant means, their costs for health care coverage would be less.
Yes. There have been multiple studies on comparing various healthcare reform scenarios. All of them show single payer to be the least expensive model by quite a large margin.
Let me swing to a couple questions that I know viewers might be interested in. Canada, how expensive is it for a Canadian citizen to have coverage?
Well, Canada has a single payer system. It leaves out drug coverage and some accident-related coverage, but it's largely a single payer system. They have no deductibles and copays at the point of service. It's all funded through taxes. They spend about 60% of what the U.S. does on health care. Their primary care docs are paid as well or better than U.S. primary care docs. Their specialists aren't paid as well all the time, but in all, physicians are paid pretty well in Canada. The administrative hassles are minimal, and people are very happy with the system. There are some waits for elective procedures, but if you have an emergency, if you need care for anything that really can't wait, you can always get it.
You need your tonsils out, or you have a terrible injury to your wrist and you have to have your bone set, you're not waiting.
Yeah, that's
okay.
right.
That's important. Great Britain, another case.
Okay, Great Britain, as opposed to single payer, Great Britain is socialized medicine. And the difference is that socialized medicine, the government funds it, and they own the care delivery system. So they own the hospitals, they employ the doctors.
Okay.
And that's full socialized medicine. Great Britain probably has had, there are some recent attempts by the Cameron administration to undermine it, but it has had probably the most cost-effective system in the whole world. But I kind of like the idea of leaving the delivery system private and independent, and it only costs a little bit more.
And we're kind of a nation of independent
Yes,
individual
right.
types, and you and I as physicians
Yeah.
know our colleagues very well. Okay, so you were speaking about, I didn't mean to sidetrack, you were speaking about some of the challenges in the health insurance industry. So speak more
The
about
other thing
that.
I wanted to say is the other major characteristic of healthcare is its complexity. Healthcare is not straightforward. If it were, you could go to the doctor kiosk, punch in your symptoms, and you get your prescription spit out at the bottom. But there are large numbers of variables. There are many people who have, allergies or adverse reactions to preferred drugs, who have complicated interactions between different medical conditions, who have psychosocial problems that interfere. And this is a big percentage of healthcare. So you can't impose central management of healthcare without a whole lot of exceptions, and that means a whole lot of administrative costs. Once you start dividing things up into these people should get care, these people doesn't, you need a bureaucracy to do that. And that's what we have, is huge bureaucracies. In the Affordable Care Act, they have means testing, they have all these different subsidies depending on your income level, they have to know your income, they have to get your tax information in order to calculate what's the right subsidy. All of this needs a bureaucracy, which is why the administrative costs are only going up with Obamacare instead of down.
That's a concern.
The beauty of single payer is it's very simple. Everybody's included. The administrative is very simple. Once they collect the taxes, they pay hospitals on global budgets, they pay doctors fee for service, and other countries have shown this is far, far less expensive and doesn't result in a whole lot of unnecessary care the way the architects of Obamacare were saying this is the problem. It isn't the problem in other countries.
So tell me why, what's your feeling? Why did we not go to single payer?
Basically, it's fear of the insurance lobby.
Okay. So the insurance lobby, yes, is very potent, and we've come to know we've got a good relationship here for the most part with HMSA and Kaiser, and it's a small town, we here in Hawaii, so we work closely with them. But there are still high costs to certain parts of the healthcare system, and there are certain rules, and we're dealing with all of the bureaucracy. Is Hawaii ready for single payer?
Well, the doctors are. We've had the past two, the current president, myself, and the one before me were all single payer advocates. I got elected to office on an openly single payer platform. So I think the doctors in Hawaii are ready. I don't have a clear idea of how much of the general population really understands the issues well enough to know. I think that if there was the will on the part of government, we could work with all the local insurance companies to come together around something that I think could work. I think that any single payer system needs an administrator. Someone's got to process the claims. That could go to one of the insurance plans. Single payer systems do allow for integrated systems like Kaiser, not as insurance plans, but as delivery systems. So the single payer system pays a Kaiser-like entity a set global budget. Kaiser pays their hospital, runs their hospital and pays their doctors, just like it is now. So that could be included in a single payer system as a subsystem. And you could organize something like that around the community health centers using Aloha Care as the administrator, and then you could have the rest under a fee-for-service single payer system. And you could make it work with the local plans. We just haven't had the political will to do it up to now.
What do you say to people that say, hey, government can't do anything right, government can't run a system? What do we say to that?
Yeah, the administrative overhead of Medicare is 3%. The administrative overhead of private insurance is 8 to 30%.
Wow, so a big difference. Why the big difference? Are we just paying for unnecessary admin, for bureaucracy?
Well, basically, you're paying for advertising, you're paying for lobbying, you're paying for all of the managed care costs of managing doctors and managing pharmacy benefits. You're paying for the risk adjustment for different risk pools when you have different people with different incomes, with different subsidies. You have to have an administrative bureaucracy to deal with all that. All of these things go away with a single payer system. There's no need for any of them.
One interesting thing too that I've been mulling over in my role as at the Hawaii IPA, where I spend a lot of time with doctors, is right now all of my docs, they spend a lot of time processing claims, getting prior auths like you described, all this administrative issues. And at the same time, we have an incredibly difficult time having enough hours to see our patients, to get people in the same day that they're sick. And we have this whole staff of people at every one of our offices and our hospitals, all processing claims, doing bureaucratic work, when at the same time we could be helping those people to get training in clinical practice, clinical support, and actually providing care. And I think that is one of the unharnessed opportunities we would have in healthcare reform if we went to single payer, or at least a major evolution of the current healthcare, affordable care climate, because all of these people have jobs that are important. They could be doing things other than dealing with this he said, she said bureaucracy. Instead, they could be doing the prevention. They could be scheduling the important tests. They could be working with people on diabetes education. Is that something that...
Absolutely, absolutely. We spend so much of our time as physicians dealing with the speed bumps that are put in our way by the managed care plans. In Queen Emma Clinic, which is all Medicaid, I kept a log for 2 weeks, and 40% of my patient encounters involved some kind of system problem. They couldn't get a prescription filled, they got bumped off their insurance and had to apply to get back on. They got switched categories and had to switch health plans. 40% was dealing with obstacles to care created by the system. That's unconscionable. And I think we should be taking care of patients, not fighting with insurance plans. And so now they want to make us coordinate care. You know, they've got to get the speed bumps out of the way and let us do our job before they even know how much coordination is needed. Yeah. All of us taking care of patients know what other specialists are needed. They know what care coordination is needed. But if you're having to fight the system at every step of the way, and all the specialists you want to refer to aren't taking Medicaid, you can't make it work.
Yeah, I think these are some major problems in the healthcare system. Now, let's bring it back down a notch here. Yeah. If we went to a single payer system and we contracted, say, with HMSA and Kaiser to actually provide some of the administrative support, what would it look like then? How would an average citizen get their coverage?
Okay, let me illustrate this with what they did in Western Colorado. Okay. Rocky Mountain Health Plans got a contract to deliver all of Medicaid for Mesa County in Western Colorado. They offer commercial insurance through employers, and they developed a Medicare Advantage plan to capture the Medicare population. They pool the money from all those, and they pay doctors the same regardless of where the money came from that individual patient. Okay. So the Medicaid patient, the employed patient, the Medicare patient all have the same access to care and the same care delivery.
So doctors don't distinguish then?
Right. There's no difference. The system pays doctors the same regardless of where the money came from. They've eliminated access to care problems for both Medicare and Medicaid. They have high morale among the doctors. They have the lowest acute care Medicaid costs in the whole country. Wow. Now, if we expand that to everybody, we would have a truly efficient system.
And so we would start with the people that are on Medicaid and Medicare here. Then we would take perhaps the government employees, and they would also be included in a plan, so they would be able to see their doctor if whoever they chose, because doctors would be asked to see people irrespective.
The fewer plans you have, the more choice the individual has of which doctor and which hospital they want to go to. And in a single payer system, you have full choice.
Got it. And what would be the downside of that system?
As far as I'm concerned, very little.
Okay.
I mean, it would be much cheaper. Everyone would be covered for all necessary care. Benefits would be comprehensive with no deductibles and copays. Everyone would participate. Hospitals would be paid on global budgets, which will eliminate their billing departments. That's 20% of their costs. So hospital care would be cheaper. The whole system would be much easier to deal with administratively. Everything would be standard. You wouldn't have to guess which benefits are available to which plan or what copays or whatever. You could remove healthcare costs from medical malpractice, auto insurance, and workers' comp by including them in the universal system. And then you only litigate lost wages and punitive damages and things like that. But the healthcare would be taken care of in the healthcare system. That would bring the cost of all those insurances down by more than half.
And you're saying we could deliver more actual care to people with some of that extra resource?
We'd have much more efficient use of the resources we had. We would have a much more provider-friendly system that would make it attractive for doctors to do primary care again. we can train all the primary care doctors we want, but if they all want to go to work for the VA or someplace where they don't have to deal with this stuff, it doesn't do us any good.
Well, I think that's a good place for us to take a break. I will say that it does make my head spin when I look at these many insurance plans and all the different performance models. It is pretty complicated, and sometimes I wake up and wonder, how does any doc survive in this system? So we're going to take a break here at Healthcare in Hawaii, and we'll come back for our final comments from our expert guest, Dr. Steve Kemble.
I'm Bill Spencer, President of the Hawaii Venture Capital Association. We do monthly luncheon programs with ThinkTech about things that matter to Hawaii entrepreneurs, investors, and business service providers. So join us on the fourth Thursday of every month at the Plaza Club. For information about upcoming events or to join our mailing list, visit hvca.org. See you there.
Aloha, I'm Josh Green, your host at Healthcare in Hawaii, Senator and ER physician. Today we've been having an extraordinary conversation with Dr. Steve Kemble, expert in single-payer healthcare systems across the country and across the world. Steve knows more about single-payer than anyone else in our state, is involved with other national organizations, and has had a leadership role here in the state of Hawaii. Until just weeks ago, he finished his term. Absolutely at the behest of his colleagues, he was asked to be the HMA president, the Hawaii Medical Association president, where he spent a great deal of time advocating for single payer for Hawaii. Now we're going to turn to Steve, and we're going to ask for his vision of healthcare 10 years from now. What would be a great system? What would it look like if we did single payer? How can we make that work? Steve.
I have a set of what I call operating principles for a truly cost-effective, sustainable healthcare system. And the first one is you want a single risk pool. You don't divide the population up into different risk pools. Everybody's in the same system. You would have public financing, private delivery of care. You would have comprehensive benefits that cover all medically necessary services. You would have no deductible and copays. You would streamline and simplify administration. You would have physician-driven quality improvement instead of corporate-driven managed care. The funding for the system should be separate and not mixed with general funds, like a separate healthcare fund that would have its own tax stream into it and would pay out the claims for the system. And then I think we could create a system that truly would be 60% of what we now spend on healthcare. It would cover everyone, no deductibles and copays, and we would eliminate all of the middlemen and the unnecessary administrative complexity of what we've got now.
And how would we pay for it? What would be the main source of pay?
It'd be a combination, basically payroll taxes, combination of employer tax and employee tax, each of which would be set to be lower than what they're paying now. So the employer, maybe if the employer is paying 10% for healthcare, it would be like 7 or 8%. And the employee, they would lose all the deductibles and copays and premium costs, but there would be a tax that would be maybe 2/3 of what they're now paying for all those things. And between the two of them, you fund the whole thing.
So you would provide some guarantees because it would be less expensive, because there would be less overhead. You would recommend guarantees that people paid less than they had previously.
Yes, exactly.
And they'd be offered an opportunity to get the same doctor, the same hospitals?
Free choice of doctors, free choice of hospitals, no restrictions.
What happens to the industries that are out there? Would they evolve? Would they change? What would happen?
Well, I think, like you say, there would be some change in roles and some retraining. I think we need more healthcare providers. At all levels, we need more doctors, nurses, community outreach workers, physical therapists, everything. So we need to retrain bureaucrats to become healthcare providers. We need some administration. Someone's got to process the claims. Someone's got to run the quality improvement program. But we need to deploy it around efficient delivery of health care rather than the convenience of the health insurance industry.
I understand. And then in the doctor's offices, all those individuals that are working to support the physician, they would become healthcare providers?
Yeah, I don't know that it would come out exactly even, but you definitely want to focus your employees on healthcare, not on bureaucracy and obstructing care.
And in an era where we're short on doctors, short on nurses, and long on cost and expense, I think that just might be the ticket.
It would be.
So great. I think we'll end on that point. This has been Josh Green with Healthcare in Hawaii. We've been honored to have Dr. Steve Kemble, an expert in single-payer systems, and we're going to have him back as we go forward in the coming months and years to describe what's actually happening in Hawaii, what our opportunities are, and how we can have a better healthcare system for you. Thanks for joining us.